Welcome back to our series. Our team is grateful you're here. Of course, seeing you in person would be preferable, but given the ongoing response to managing the SARS-CoV-2 pandemic at Hopkins, these virtual platforms have proven to be an efficient means of sharing information, education, and discussion. A couple of updates. This is our last session of this winter-spring semester. We are working now on fall semester offerings, which will start in September, and we'll be updating you very shortly. Please keep connected. You can find our updated programming in our newsletter on the web. Just Google Greenberg Bladder Cancer Institute. And I wanted to again draw your attention to our group of programs specifically tailored around the experiences of women with bladder cancer, developed and led by Drs. Armin Smith and Jeannie Hoffman-Sensis, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg. Their June 7th program will feature Dr. Elizabeth Platts for a discussion around population science and cancer survivorship. Again, all of these are up on our site. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I'm grateful to all of you for joining us today with two of our clinical leaders, medical oncologist, Dr. Noah Hahn, and urologist, Dr. Max Cates, for a discussion around their unique perspective in caring for patients and families in a multidisciplinary setting. I also look forward to hearing about their work together on an evolving multidisciplinary clinic for patients with non-muscle invasive bladder cancer. I hope you'll allow me the chance to provide brief introductions for our speakers. So Dr. Hahn is professor of oncology and urology and serves alongside me as the deputy director of the Greenberg Bladder Cancer Institute. He earned his MD from Indiana University School of Medicine, completed his residency in internal medicine at Duke University School of Medicine, and performed a fellowship in medical oncology at Indiana University School of Medicine. He joined the Hopkins faculty in 2014. Prior to joining Johns Hopkins, Dr. Hahn was the director of the genitourinary medical oncology program at Indiana University and chief scientific officer for the Hoosier Oncology Group, a cancer research organization that evaluates innovative and promising approaches to cancer treatment. Dr. Hahn serves our community at large as a member of the Bladder Cancer Task Force for the National Cancer Institute's Genitourinary Cancer Steering Committee, and is chair of the Bladder Cancer Subcommittee of the Eastern Cooperative Oncology Group, or ECOG. Dr. Max Cates is associate professor of urology and oncology in the Brady Urological Institute. Max is a Brady-trained urologist who attended Mount Sinai Medical School in New York. Max is our urology leader here in the Greenberg Bladder Cancer Institute, where his practice focuses on patients with bladder cancer. He has received recognition nationally from the American Urological Association and the Bladder Cancer Action Network, Advocacy Network, among others. However, it is the feedback from his patients and families and his strong sense of communication which has inspired this conversation today. I'm grateful for Drs. Hahn and Cates' willingness to come to our session and share their expertise with us. So they've agreed to speak about their work together, and then we'll jump to a larger group discussion. And so I would ask for attendees to bring questions into the chat, and after their conversation, we will have ample time for group discussion.
Okay, thanks, David, as always, for those very flattering introductions. It's a pleasure to be here today. Max and I are going to talk a little bit about the topic of today, sort of treating the whole patient. And I think what we're going to try to cover in a loosely sort of organized, free-flowing discussion is some of the standard approaches and terminology in bladder cancer. I think many of us are very familiar with sort of the term multidisciplinary care. We'll talk a little bit about what that means to us, what it's meant the bladder cancer field. And then I think what is probably most exciting and hopefully of interest to our audience today is how rapidly that term is changing and taking on different sort of meanings in some what used to be, I would say, non-traditional patient populations. And so hope that we can set the stage, for some good discussion questions, and hopefully it'll be informative. So Max, I guess, we can start off a little bit with, when we talk about treating the whole patient, let's just start first with what you think of, in a traditional context for bladder cancer patients, what the term multidisciplinary care, has traditionally meant. From your perspective as a urologist, and I can add some flavor, I guess, from the oncology side a little bit.
Yeah, I'm so glad you kind of asked it like that. Basically, when I was in training, even multidisciplinary bladder cancer care was really thought of as a sort of niche section of bladder cancer care, in which there was basically a medical oncologist and a urologist who would work together specifically on patients with muscle invasive bladder cancer who were undergoing chemotherapy before they had their bladder removed. And that was kind of where it started and where it ended. And in the last, 10 years, that's really changed. And I don't even think we think of multidisciplinary care as a specific part of bladder cancer. I think we think about it as, and maybe we're unique in this, and maybe we're not, but we think about it as everybody with bladder cancer. And part of that is because our group has really sort of pushed the boundaries of where for example, medical oncologist would traditionally be involved in a bladder cancer patient's journey, and where a surgeon would traditionally be involved in a bladder cancer patient's journey. And we can talk about that. And by the way, a radiation oncologist's involvement, and that's just kind of the beginning. So, for me, when I have a patient with bladder cancer, and it does not matter what the flavor or the stage is of their cancer, when they come in, the very first thing we do is we have a conversation, a goals of care conversation, in which we say, okay, well, what are your priorities? What's important to you? What's meaningful to you? What kind of life do you want to lead? And we have that conversation in as authentic a way as possible, in order to understand, okay, so where is that going to take us now? And oftentimes, no matter what the stage, that will involve a team approach. And so when I go back to your question, when I think of multidisciplinary care, I think of a team approach to someone's care. And that often includes a lot of different disciplines. But I'm curious about how you would answer that question, and sort of what you would say, because I kind of went off in my little tangents that I like to go. I'm curious what you would say.
Well, I think it's, I think both of us have seen some changes as to what that means over our careers. And I think it brings it back to the focus of kind of today's topic of, really treating the whole patient and, thinking about all aspects of their care. When I think back about multidisciplinary care, when it was first introduced to me in terms of bladder cancer, you're right, it was a relatively new concept if we go back to kind of 2005 to 2010 kind of range, where we weren't quite sure how comfortable we were with it as physicians, as patients, in terms of trying to get the logistics figured out. We had some initial studies that said, hey, we kind of need to be doing this. The results with sort of sequencing chemotherapy, surgery, et cetera, seem to provide an advantage in cure rates. But I would say multidisciplinary care at that time meant multi-specialty evaluations of patients, and in large part sequential handoffs. And I think that was a good first start. And I think a lot of that evolved because that was new at the time. And I think from a training and an education standpoint, none of us were trained, you know, in that environment. So as medical oncologists, we traditionally were trained with advanced disease patients and, you know, managing side effects from sometimes more toxic therapies. I think from the urology side, there really was not a role, you know, at that time for systemic therapy for muscle invasive patients. And I think building off of that model, you know, I think we learned from each other how to build programs that incorporated, you know, different perspectives, different specialties. But I would say, and this is what's something I want to kind of give back to you about kind of perspectives in the last, you know, say 10 years. I would say the last 10 years have changed dramatically for a couple reasons. You know, there have been a lot of new therapies coming forward for bladder cancer in advanced patients, and that's been tremendously beneficial for our advanced patients. But I also think that there has been a major shift, I would say, in the skill sets of physicians who care for bladder cancer in all fields in the last 10 years, where there has been an increased emphasis in their training, in their residency, in their fellowships, in their early faculty years, to at least gain an appreciation, I think, for what the other specialties do, what their strengths are, how they view things, what they can add to the discussion. And what I've sort of seen, instead of this multidisciplinary term, which to me, it almost has a negative context, because I think it sort of feels like it puts people in a certain box. And it's good that we bring people with skills together, but in my mind, that term has sort of evolved into sort of multi-physician, you know, care. And I've learned in my career that, you know, my colleagues that are not oncologists, whether they're surgeons, radiation oncologists, pathologists, you name it, that there's a lot to be learned there, and an actual collaborative mutual discussion about what's best for the patient. I think we're seeing that now. And I think that's what multidisciplinary care intended, but it takes a while. Takes a while to get comfortable and actually see that. And I feel like I've seen a conscious change, say, in the last 5-10 years. I'd be interested in your perspectives, you know, as a surgeon in this field, what you've seen among surgeons coming into the field, but also even as you approach it when you're talking with, you know, your trainees, residents, fellows, even within the training program at Hopkins and beyond.
Oh yeah, I mean, definitely. I mean, I think there's been a couple trends that I've seen. But I think clearly the urologist that is sort of graduating their training program today needs to be very comfortable and facile with understanding the basics of, for example, radiation treatment and all of the sort of FDA approved drugs. At the very least, the FDA approved drugs in their field. So if it's bladder cancer or prostate cancer, they would need to understand that. And maybe that was the case 10 years ago, but the thing is, in bladder cancer, there are a whole lot more drugs that are now approved. So the bar is a little bit higher. One of the interesting things that has also happened concurrently with that is that we're actually getting a little bit more refined in our surgery. So for example, the average length of stay 10 years ago in the hospital from a cystectomy was about 10 days. And the average length of stay today is somewhere around 5 days. So we've cut the amount of time a patient is in the hospital recovering from surgery in half. And that's sort of a marker of how we're improving in that. And so so one example of multidisciplinary care is patients now have access patients with maybe more advanced disease have access to all of these wonderful new therapies that have recently been FDA approved in the last 4 or 5 years. And so they're having better responses, some of them, not all of them. And where our surgeries, I wouldn't say necessarily they're less, they have less complications, but we're improving them. I'll say that. And so now we're starting to kind of move the needle a little bit in our appetite for maybe doing surgery in a patient who, say, has had 3 or 4 years of a durable response to one of these new agents. And that's totally new. That's something that I'm now seeing several times a week in consultation, and is very exciting. And I'm kind of curious, as somebody who's seen the arc of these drugs from early phase trials, now kind of in clinical use, and now seeing patients with these durable responses, and now trying to get the surgeon back involved. What's that experience been like, and sort of how has that changed?
Yeah, I think you bring up a really important point, and I think sort of pertinent to sort of talking about treating the whole patient. We've been very fortunate in the medical oncology field, to sort of see some of the new drugs come through first, because as all on today's call and the bladder cancer community are aware of, it took a long time for us to get the attention of pharma industry investments, et cetera, to be able to bring, active therapies forward. So I can still remember, 2014, when I came to Hopkins, was when the first sort of phase 1 trials were enrolling of some of these new immune therapies, and they had some bladder cancer cohorts. And it was immediately obvious in some patients, not all, but in some patients, it was immediately obvious that we were seeing some profound benefits that we had not seen before. And that's an exciting thing to see. That doesn't happen that often, as you go through the career of seeing something that within the first 3 to 4 patients that you treat, immediately this is different. Now, you don't know exactly how to position it. It's not going to by itself, cure every single patient. But it's really exciting to see that. So fast forward, as the clinical trials became larger and more people started getting access to these medicines, and then eventually we saw some FDA approvals, and then now sort of second and third wave of kind of new medicines, new targets, when you talk about, some of the targeted therapies to specific gene alterations like FGFR3, when you talk about antibody drug conjugates, like some of the new medicines like N4-tumab and sacituzumab, we started having a very fortunate challenge to have, which is that some of our patients with advanced disease were achieving very good control of their disease outside of the bladder. And we started having some patients who still had their bladder or still had disease in the upper tract, still had their kidneys and ureters in place, who would run into some local, symptoms, whether it be ongoing blood in the urine and needing for transfusion, whether it be just irritative voiding symptoms, discomfort, strictures, obstruction of ureters from, tumors in the upper tract. And it posed a question to us, okay, what do we do now? We were never into this space. We were in uncharted territory. And we started having discussions with patients sometimes from a quality of life standpoint. If they were having incredibly irritative local bladder symptoms, well, are we really considering doing a cystectomy in a patient who 2.5 years prior, we were not sure what was going to happen? We were having hospice discussions. Are we really going to take them to a big surgery? And the answer is yes, for sure. In some patients that are very, selected appropriately in centers that deal with this, that in some cases, the quality of life from their local tumor that is the only site of disease that hasn't been controlled by some of these newer therapies. Sometimes from a quality of life, it makes a lot of sense to say, yes, we do need to consider, what we typically would think of as an aggressive surgery in the past, and do that. And we have. I think we treaded those waters very cautiously at first, because it made a lot of us as physicians, I think, a little uncomfortable to think, wow, this is a big surgery, and we're not sure on the back end, how it's going to turn out. But I think we've gotten a little more comfortable with that. And there are other reasons, scientific and theoretical to think about that there are changes, in the actual cancer tumors over time. And it may be that certain sites, of disease may be the only sites that are still sort of shedding, new metastatic cells. But that treating the whole patient and sort of being, I guess, having the wisdom, the courage sometimes to go into an area where there is no established guidelines of what we should be doing, where there is no evidence. That's one of the things I think has been rewarding, for myself as a physician, but I think many of our patients, at the GBCI, and I think at a lot of the centers that we work with, we're gaining experience in that. And from an oncologist standpoint, I got to tell you, it's incredibly rewarding to see patients, to see their quality of life improve with, combined sort of views and perspectives and skills. Wonder if you talk about that a little bit from the urology side, about your initial experiences of sort of thinking about bringing the local therapy, options back on the table in a space that we didn't before, and sort of some of the factors that weigh in your decision, and how we have kind of worked together. We worked on several patients together, but also with the GBCI and other physicians, how we approach that.
Sure. So, yeah, I mean, I think that, it's very interesting because the thing, you need many physicians when your goal is to do something that's a little bit maybe unorthodox or less straightforward. So I'll give you an example. So, and I'll get back to your question, but when your goal is to say, okay, well, we are going to try to utilize novel techniques and novel therapies to preserve bladders as a general guiding light, if we can. Well, that is actually a lot harder than saying, okay, well, every person with bladder cancer that comes in, we're going to cut it out. And it really only takes one doctor to do the second thing. But the first thing takes a lot of thought, a lot of planning, a lot of discussion. And so that's kind of an example. And so that's true for high risk non-muscle invasive bladder cancer, where maybe the most straightforward thing to do would be to say, okay, well, let's just cut it out. But is it the right thing to do? Well, probably not in everybody. Probably in a lot of patients, we can preserve those bladders with some thoughtful either clinical trials or novel approaches, working with multiple teams of doctors. With muscle invasive bladder cancer, similarly, sometimes the right thing to do is to go forward with surgery, for example. But sometimes there might be other options that we can think about to preserve bladders. And by the way, we often ask patients, is this a bladder worth keeping? Are you getting up 5 to 6 times a night? Are you having a lot of frequency, urgency? Well, then maybe it's not. But assuming it is, that's a guiding light. So back to your question about advanced disease, maybe the most straightforward thing to do, and maybe this was what was historically done, is not to go back to the surgeon when the patient initially had tumor in a lot of different parts of their bodies, and now really it's just located in the bladder. And by the way, they have a lot of symptoms with that tumor in their bladder. But is that the right thing to do? Well, probably not. Probably the right thing to do is to say, okay, well, we have this patient who's had these 3-4 years of really good response. well, can we keep this going, and can we improve their symptoms? And so let's go back and work as a team. And so my point here is that in every sort of space within bladder cancer, the simple thing may not be the best thing. And probably a lot of times the best thing is a team approach. But that's why it takes a sort of clinic where you and I are sort of sitting across from each other, for example, or it takes constant communication to kind of pull that off. So that's kind of how I would answer that. And I was kind of trying to get it back to our clinic, but I didn't really have a lead in there.
Yeah, no, I think that's good. I kind of, again, I think for the audience, I can kind of describe a little bit of our sort of clinic at the GBCI in terms of how me and you operate, but also how many of our physicians in sort of their unique sort of areas work together. You know, again, getting back to sort of, when we talk about multidisciplinary care, a lot of times it's been multiple specialties, and in a lot of cases, it may be co-located. They may come together, you know, for a day a week to kind of see people. A lot of times it may be in different locations. Sometimes in the community, it's not possible to be together. So you may actually be in different offices from the urology and medical oncology side. Our clinic at the GBCI has evolved over time, you know, over the last 6 to 7 years. But our clinic, at least when Max and I see patients together, whether it be traditional muscle invasive bladder cancer, what we just touched on, like if we have a patient with advanced disease who needs local care, we'll talk in a second about kind of early stage bladder cancer. We literally sit side by side. So we were in clinic all day together today, and we are every Monday. I would say in my medical career, it's been probably the most rewarding experience I've ever had. And I think that it's impossible to underestimate the advantages, the learning, and sort of being able to kind of come up with sort of creative and you know, evidence-based approaches to try to put together and put the patient first in a lot of different areas where there's not evidence. And I think we're seeing a lot more of those areas where when you go to try to find a randomized clinical trial that fits exactly the patient I'm seeing today in front of me in clinic, it gets harder and harder to find that because, you know, bladder cancer is getting more sophisticated. We know more about the nuances and the different diseases within the disease, so to speak. And we have the luxury, you know, at the GBCI, and some of our colleagues at other centers do as well, that we get to see a high volume, and we get to see experts at every aspect of the care. And so we're able to see kind of the rare subsets of bladder and upper tract disease and identify them and learn from them as we treat them over time, sometimes in ways that our colleagues that just don't see it as much don't have the advantage of. So I think it creates a culture, you know, that doesn't exist everywhere, that every single week we are learning from each other and refining how to put the patient first in a way that evolves over time as new information comes out, our own experience with certain patients. And to me, that's been, like I said, the most rewarding clinical aspect of my entire career. And you know, I look forward to Mondays. A lot of people dread going in on Mondays. I actually look forward to it. So I guess I would ask you, Max, you know, you've been in a lot of different places. We all have as we go through different training and, you know, residency fellowships, sometimes even as jobs as we change over our careers. What's your experience about how we sort of do, you know, the multidisciplinary approach at the GBCI compared to, you know, other places, and also some, you know, some challenges and things that like I said, we have the luxury at the GBCI where we've been placed together, and what kind of advantages that that brings to the patient experience that we're lucky to be able to provide.
Yeah, I mean, I think that the idea of a multidisciplinary care alone without individual providers who are more than just engaged in bladder cancer, but this is what they get up in the morning and think about, is kind of it's not the complete package. So one of the things that I very much value about it is that within our sort of team at the GBCI, we have really in every sort of discipline, we have people that wake up in the morning and they're thinking about bladder cancer. And that is, it's not just like they're the urologist sort of on call for the day that's covering sort of the bladder cancer clinic. And that's a really important distinction. And there was a question in here about multidisciplinary care ever including, you know, all these other subsets, radiologists, nutritionists, and physical therapists. And it kind of already does. I would answer that question with. So we have nutritionists, for example, that are seeing our patients. Every single patient now that's recovering from surgery is seen by nutritionists. And that's a program that we instituted this year. So we're still trying to broaden our definitions of multidisciplinary care. We have a radiologist, Steve Rowe, who I think has spoken at one of these GBCI grand rounds before, who's sort of one of the preeminent what's called nuclear medicine radiologists, and provides input at our weekly tumor boards where we discuss complex bladder cancer patients. So what I would say makes it sort of unique and successful is that the people involved are not just covering sort of a clinic where they happen to be from different specialties, but really it's a bladder cancer team that's cross-trained and understands the other side, as you said. And that's really, I think, what makes us, you know, unique, to be honest. The other thing that I think makes us unique is that we are so engaged in the lab, and that we have partners that are equal members of our team, like Dr. McConkey, like Dr. Woon-Young Choi, and a host of other people who are working with us in broadening what we understand as multidisciplinary care by working very hard to say, find biomarkers that predict response to the therapies that we're using. And so we're not just sort of standing here in 2022 thinking about what's the right thing for right now, but we're sort of pushing the definition of what is multidisciplinary and how can we broaden our team. And honestly, going back to my earlier statement, that makes our job you know, sometimes more complex, right? The more the bigger the team, the more complex care. But that's not the question that's relevant. The question that's relevant is it better for the patient? And it absolutely is. And so, you know, I would kind of answer it like that. There's a question in here in the chat that I'm wondering, that I'm curious if you answer, and I do want to get back to non-muscle invasive multidisciplinary care, but this is about what your thoughts are on trimodality therapy being on the rise, as well as other new or novel technologies and how that fits in, and just wondering what your thoughts are on that. And I'm sorry, I'm just noticing the chat, so I'm going to try to be responsive to the chat.
Yeah, I'm kind of looking at it as well.
Okay.
I think we're going to shift a little bit to some non-muscle invasive, and then I think I want to address some of this and open it up as well, definitely to the audience for kind of some ad lib stuff. But relevant to trimodality care and some of the, you know, some of the rise that we're seeing with this, I think this is from a couple different factors, but I think largely, you know, from patients, you know, and patient interest. The evidence has been there for a long time. I think there has been some more recent kind of long-term experiences and some things that have kind of gotten a little bit more on the front page, you know, I think in a lot of our international sort of clinical and research meetings. But I think the bladder cancer advocacy deserves a lot of credit for this, in that, you know, refusing to not allow discussions of muscle invasive bladder cancer to continue to take place without trimodality therapy being part of every discussion. And, you know, trimodality therapy, and this also goes back to, I think, one of the questions about sort of coordination of care across a lot of these kind of novel ways to look at, you know, multidisciplinary care. It is challenging. You know, you got a lot of moving parts. And if you're going to implement a therapy that requires three modalities to be working in concert with each other, then you have to invest in some infrastructure to be able to consistently get those evaluations, communications, and treatments handled, and that they're handled consistently all the time. And that is not something I think that every center, even academics, was prepared to do as trimodality first, you know, started becoming more of a first line accepted therapy. I think that's changed a lot. And I think it's changed a lot because of patient advocacy. And, you know, whether it should have taken that to sort of happen or not, I think we can have a separate discussion. But I think because of that, I think we've seen a rise in sort of trimodality usage and interest. I also think we've learned how to use it better. I think we've learned how to identify which patients are much better suited for it. And I think become much more comfortable with saying, you know, that is actually on par, you know, with cystectomy, and absolutely we should consider it, you know, in appropriately selected patients. So I think we've gotten better at it. And I think the awareness from patients and physicians certainly has increased. So that's why I think we're seeing that. Now we're also seeing trimodality starting to extend. You know, should we be thinking about it even in some non-traditional populations that are being looked at in clinical trials now? So populations maybe with just lymph nodes that are, you know, involved in the pelvis, but not metastatic. We're still learning there. And so I think there is hope that we may be able to do that. I think your point, though, about making sure that we're trying to preserve bladders that are functional, you know, that still retain quality of life for the patients, that's where I think having a team of physicians who are familiar with that really helps. So kind of along those lines, you know, we talked a little bit about advanced patients where we're bringing, you know, urology kind of in settings where we never did before. There's been a lot of talk, I think, in the last couple of years about non-muscle invasive bladder cancer. And, you know, we've not traditionally thought of non-muscle invasive bladder cancer patients as a multi-physician, multi-discipline, you know, population. We didn't have anything really to offer from a systemic standpoint. We have had the first FDA approval of an immune checkpoint inhibitor in Pembrolizumab a couple of years ago. Has not taken off like wildfire. I don't think that surprised a lot of us, but you know, I think at the GBCI we've had a little bit more kind of forward-thinking approach about what does multidisciplinary care mean for non-muscle invasive patients beyond just standard approaches, but also research and what does the future look like. And you know, as a urologist, wonder if you might be able to comment a little bit about how you see multidisciplinary care evolving in non-muscle invasive patients, again, with sort of putting the patient first, the whole patient, and you know, how we approach that at the GBCI.
Yeah, well, you know, I would say that we are, you know, very fortunate to have somebody like you engaged in non-muscle invasive bladder cancer. So for those listening on the call that might not know this, actually, Dr. Hahn is probably at this point the sort of definitive leading voice from medical oncology for sure on non-muscle invasive bladder cancer. So having that, and why is that value added for the clinical program? I mean, it's immensely value added because basically right now, for example, we have several that I can just think of off the top of my head, clinical trials written, by Dr. Hahn, that are challenging sort of the status quo in non-muscle invasive bladder cancer by, for example, giving some systemic agents with, in certain situations, some intravesical therapies for different types of bladder cancer. So, what do I think that is? So I think we are sort of at all the way to one side of where the puck is going. Like we're the one, we're pushing the puck basically in non-muscle invasive bladder cancer. But the goal is basically, if you think about it like this, metastatic patients with metastatic cancer go through a first line therapy, a second line therapy, a third line therapy, a fourth line therapy in some situations. Whereas right now in bladder cancer, patients get BCG for non-muscle invasive bladder cancer. And then there really isn't, a standard second line FDA approved drug that everybody's giving. So many will go on to surgery to have their bladder removed. And we want to make it into a first line therapy, a second line therapy, something where we have a way to preserve these bladders in patients who want that, that limits, progression to more advanced cancer, but can once again preserve bladders. And so to do that, we need to bring in novel therapies and the systemic therapies in certain situations and new ideas. And to be honest, as a urologist, I love that those new ideas are coming from a discipline that I didn't necessarily train in, and so I can learn from. So a perfect example of that is the recently FDA approved Pembrolizumab, which, to be honest, hasn't taken off like wildfire. It's really probably in its current state only useful for a small group of those patients. But the future may be combination of that therapy with another therapy. So we need to understand those therapies as urologists. And so I have sitting next to me, the world expert on this, who's written those trials, and we're able to offer it to our patients in clinical trials. And so, God willing, when it gets FDA approved, we're going to be early adopters and be able to offer that to our patients. So that's just kind of one example. But there's many others. I'm curious about your journey, and then maybe, for the last 15 minutes, we'll try to answer some of these questions. But I have to go back to this because I'm curious about your journey, because you're really kind of unique. There's not a lot of people like you that are kind of pushing the envelope in non-muscle invasive bladder cancer with these systemic drugs in particular. And I'm curious about how you got there and sort of where you see that sort of multidisciplinary care.
Yeah, it's kind of sort of how the hell did I wind up in this sort of crowd? Yeah, it's interesting. For me, in terms of non-muscle invasive, and I think what you kind of described about what we do at the GBCI is really spot on. It's really invigorating for me to work with you and our colleagues at the GBCI to sort of learn in the non-muscle invasive space and others. But I got interested in the non-muscle invasive space at an early stage in my career, very shortly after fellowship. And initially, I was at Indiana University. We had an incredibly high volume of bladder, prostate, urology, sort of surgical cases, and a great urologic oncology program. There wasn't a lot happening in bladder cancer. Immunotherapy hadn't kind of gotten there yet. And my interest in non-muscle invasive bladder cancer, simply put, was purely a numbers game. When I looked at kind of the statistics of where bladder cancer was diagnosed, how many patients presented with non-muscle invasive, muscle invasive metastatic, how many patients eventually were passing away from metastatic disease, it was very clear to me that the majority of patients were presenting with non-muscle invasive bladder cancer. And the second thing that got me interested in it was this idea, again, from a research standpoint, of being able to study pre and post-treatment tumors, having access to them, and the standard of care in non-muscle invasive to get urine samples, repetitive TURBT tumor resections. It, in my mind, presented a somewhat ideal situation to really understand not just whether treatments work, but sort of the why. Why did tumors progress? Why did treatments not work? And what are the targets? We got sort of lucky, I would say, in that, you know, with immunotherapy and different things started heading that way. But the other part of it is, I think, more just a philosophical, like, how are you wired kind of question. And I love the fact that we make progress in metastatic patients, and in having taken care of patients, and having, having had family and others, as many of us have experienced sort of cancer, that kind of thing. I do not underestimate how valuable it is to, be able to slow progression and prolong patients being able to reach milestones. But maybe I was a little bit foolish, maybe a little bit almost even naive. But at the beginning of my career, I had an ambition that I said, I don't want to delay cancer growth. I want to cure it. Like, I want to cure it in at least some patients. And it just seemed to me that the chances for that would be better with less volume, less extent. So that's kind of how it started. I eventually, very early in my career, I remember I went to an ASCO AACR clinical trials workshop. That's sort of a faculty development, fellow development skills. And I remember the trial that I wrote, which I still want to do, was a trial of decitabine, an agent approved for leukemia, but wanting to look at it at modifying some of the cancer suppressor genes. And I wrote a trial that was in non-muscle invasive disease. Didn't know if we could do it at the time. And then that evolved into one after another. FGFR became a target. We did a trial there, and then the checkpoints kind of moved into that setting. And I think it's been interesting to sort of look at this evolution of, patient versus physician acceptance of certain levels of side effect for certain clinical benefit. So it's a lot different talking to a patient, would you be willing to take on short-term side effects if there's actually increased chances of cure, if it's actually proven. We haven't proven that yet, in non-muscle invasive disease. So it's still a discussion. But we have done some work with the Bladder Cancer Advocacy Network, survey-based, looking at sort of these differences. And it turns out that, at least our initial investigations in that patients are willing, to, take on potential risk if they feel that there is a realistic chance for gain. So that's how I wound up in it. And then I think as I came to the GBCI, I was fortunate to find, a bladder cancer community and translational community in radiation oncology, pathology, et cetera, that were very interested in developing approaches to that particular population. And at this point, I would say it's truly, it's truly a teamwork approach, and that's both at the GBCI and within the field. I've been lucky to be in certain positions, but none of this happens without teams, that's for sure. So that's how I got there, but I'm pretty excited about what we're doing. I think in the remainder of the time, why don't we take on a couple of kind of the chat kind of questions. I think we talked a little bit about some of the nutrition aspects. There was a question here, another question for Dr. Hahn. Okay, I'll take a look at that. About I'm going to let you answer this one first, though, Max. It's about sort of BCG duration and things. This is a question about Cytoxin.
Oh yeah.
Had exposure to that, and then sort of the BCG duration. How long should we do that? And then I'll read the question here, another one for Dr. Hahn, and kind of come to that.
Yeah. So, if you were to come see me in clinic, you'd get the phrase, I will tell you what I know, and I will tell you what I don't know. So what I don't know is how Cytoxin in women affects BCG efficacy. I think it's a fascinating question. Not sure there's a lot of data on it, but it's interesting. How long to treat with BCG, and should BCG be continued intermittently for years later? The answer to that is yes, that is what we do. So BCG is given as an induction course once a week for 6 weeks. And certainly that should be, if a patient has a good response, and I would say certainly if they had T1 with CIS, as in the case that's being asked, we would usually recommend a maintenance course where they typically would get it once a week for 3 weeks, every couple months, or up every 6 months. And we would do that out to 3 years. So the answer is yes. And usually we recommend maintenance therapy, because if something is working, we want to see that it continues to work, and that we can prolong that we can reduce those recurrences in their bladder cancer for at least 1 to 2 years, because we know that if we can make it to 1 year without a recurrence, our risk of a recurrence goes precipitously down. And once we're at 2 years, even further down. So that's how I would answer that question. Noah, was there?
Yep.
I think there's one for
Yeah,
you too.
there's a question directed to me, but I'll also kind of bring you in on it as well. It's about one of the chats about having an original diagnosis in 2013 of a T1 high grade with CIS, presumably treated, but since September of 2019, having sort of repetitive suspicious cytology despite really extensive workup, cystoscopy, CT scan, ureteroscopy, retrograde pyelograms, nothing can be found. As an oncologist, what do I think about suspicious readings? Should you be concerned? Some have said atypical and suspicious are the same. What are your thoughts? I mean, I kind of look at that and I, it's a challenging sort of issue, because, when you've had confirmed high-grade T1 CIS, particularly CIS, I think we worry about the remaining urothelium being at, a lifelong risk to develop some disease. And I think a question comes with how extensive and how far do you chase it and how often? The workup that I kind of see there, I think, is very, very thorough. And I'm not sure there's anything more, that the physicians we could recommend or we would do at the GBCI. I will make one comment about atypical versus suspicious. When I see on a cytology finding just atypical urothelial cells in a treated patient or somebody who has recently got BCG or systemic treatments or has had urinary diversions, I don't generally make too much of it as a physician, because atypical findings are very, very common. If the pathologist or the cytopathologist has specifically said not atypical, but they say suspicious for high-grade urothelial carcinoma, that gets my attention a little bit more. That to me is them telling me, hey, I'm worried about this. It doesn't meet the criteria. I can't actually call it cancer, but it's a little bit more than just some atypical cells. So in that case, if I see it and I'm following someone with, a non-muscle invasive disease or long-term follow-up, I'm usually going to get on the call or on the phone and call Max and say, hey, do we need to get this person in and have you take a look and, do a biopsy or do something? Max, I don't know. What do you think about sort of those clinical sort of scenarios?
Yeah, I mean, my take on cytology is that oftentimes patients will think, and a lot of clinicians too, that these definitions are hard and fast. And the truth is that they're subjective too. A cytopathologist is looking at a slide and trying to interpret the way the cell looks. And so usually when it comes out as cancer, that means, it's pretty likely that's a cancer cell. But when it comes out as suspicious or certainly atypical, then it just looks abnormal. And in a patient who's had any intravesical treatment, I always tell patients, I'd be shocked if it's not atypical. Your urothelium, the lining of your bladder should be abnormal after you receive a therapy. So probably for the rest of your existence, anytime that urine comes out, it's going to come out with a cell that's not perfectly shaped, that's not a cancer cell. So that's how I would interpret that. There's a pretty interesting question here in the Q&A that I kind of wanted to answer, which is, what do you require for a consult from a patient who may be in need of a second or third opinion, who is being treated in a smaller urology practice setting? Can you collaborate with the local urologist? And I love that question, because I view my role, and I wonder if Dr. Hahn views his role, but I certainly view my role as being a resource to the community, and especially urologists. So There are probably around 140 or so urologists in Maryland, and many more in a lot of the places people come from: Delaware, West Virginia, Southern Pennsylvania, DC, Northern Virginia. You know, where patients will come every day. And a lot of times it's not feasible, for example, for a patient to drive up and get BCG here when they live 4-hour drive away. So a lot of times the intention is that they'll come up, get an opinion, and then I'll work with their urologist. And one of the really cool things about what that's done after kind of doing this 2-3 times with the same urologist is now they'll call me up, and maybe a patient won't even come up, but they'll ask me a question about sort of how you would manage this patient. And so I view myself and I view our team as a resource for the region. And we are not just here for second opinions for patients, but we're really here to help improve the quality of bladder cancer care in the region. And I take that role, and I know that Dr. Hahn does too, and our team does, very seriously, and sort of as part of our ethos and you know, the creed. Yeah.
Yeah, I just typed something kind of to respond to that, just in terms of contact, like my email and so forth. I think at the GBCI, most of our investigators, want to be resources to the community at all different times. We do have sort of intake to be able to do a formal, so consultation. So if someone really wants a formal medical evaluation of all of their sort of findings, then typically we will route that through our new patient offices to make sure that all of the appropriate, the pathology, the images, things that they're there, so that we can give them, the full evaluation. But I think separate from that, sometimes I think patients, and probably more often, sometimes need to know how to just get the ball rolling. We can work with local physicians and urologists. Sometimes there's physician to physician education. Sometimes we learn from the community some of the challenges they're facing that maybe we're not seeing, and vice versa. So I think most of us are always ready and willing to sort of try to be a part of helping the patient and being an advocate for them. So that's why I just kind of sent in, I think Max had kind of had earlier his email contact. And I put on there just a disclaimer that sometimes the volume, it might take a day or so for me to get back. But it's certainly, I'm willing to field those questions. And a lot of times, is if there's something and it's just a little bit too complicated, I just kind of can't see that. A lot of times I will just call, I'll arrange a time, to speak with the patient or the physician and just say, let's walk through this. With that, in that setting, I think can be extremely helpful. In those kind of settings, it's really important to just say that's an informal, just in the interest, trying to help you on your way. It's not having access to all the information. So I would never sort of claim that to be, medically binding kind of evaluation. But I think we want to be there, and we want to be available for all patients. That's why the GBCI was, founded. And if they choose to come and have their care at the GBCI, that's great. But if we can make an impact throughout the world, for patients everywhere, that's what we want to do. So that's kind of how I approach that. And I think I was trying to look at other questions, covered most of them. So I think this hour went pretty quick. David, I didn't know if you wanted to have some parting sort of thoughts there or comments, but this was a pleasure, and we're happy to do this anytime.
No, I would just thank both of you, brilliant as usual, and also our audience for asking some really good questions and being engaged in this discussion, and echo what they both said. We're here to be a resource for everyone, not just those of you who choose to come here. So hopefully you'll take Noah and Max up very seriously on their offer to be a resource for you. And thank you all. Don't forget about the women's program next month. And we can't wait to see you again during this series as it continues next fall.
Thanks, everybody.